Session on nerve and muscle pain. So peripheral nerve entrapments, myofascial pain, trigger points, these hide in plain sight. And many of us can think of patients who have come into our clinics with these conditions, and they come in and they present for what seems like a musculoskeletal injury, and they have a stack this big of their $1 million workup to date, and it all looks kind of normal. And we kind of think about what do we do in these situations. So our speakers today are here to help us all be better equipped to identify and treat these rare but troublesome injuries that are in our patients. If you have questions throughout the session, please use the app to ask your questions, and we'll do a Q&A at the end. So to get us started, I'll give introductions for everyone, and then they'll come up and teach us great stuff. So followed by Gary Ho, who will talk about perineural hydrodissection. So Dr. Ho is the program director for the INOVA Fairfax Family Practice Sports Medicine Fellowship, and he is a leader of the National Capital Sports Medicine Consortium. There, he's imparted an extensive knowledge and his ultrasound acumen to countless fellows in the DC area. He's a fellow of the American Medical Society for Sports Medicine, the American College of Sports Medicine, and the American Academy of Family Physicians, and also serves as a team physician for George Mason and the DC Divas professional women's football team. He'll be discussing perineural hydrodissection. What is the evidence? What is the best practices?
Hello and good evening, everybody. It's really great to be here in person, seeing a lot of familiar faces and meeting some new ones. Really excited to present this talk, and looking forward to our discussion that follows. I've got a lot to cover in 25 minutes, so we'll just jump right into it. I have no relevant financial disclosures. So I'm going to be talking about ultrasound-guided perineural hydrodissection for the treatment of entrapment neuropathies as encountered in sports medicine. We'll talk a little bit about anatomy. My fellows know I love anatomy. We'll talk a little bit about pathophysiology, some terminology and definitions, and then we'll talk about some technique, and then we'll wrap things up with a quick look at the evidence and what the literature has to say about this really neat procedure. So a little bit about the anatomy, and I know a lot of this can be dry, but it's really relevant, and I think it's important to think about this as we kind of think about what we're actually doing with our procedures. So just recall that the functional unit of our peripheral nerve starts with the neuron, specifically the axon, depicted here as a myelinated axon with its connective tissue sheath, which allows for saltatory conduction. Multiple similarly destined axons are then invested together by a kind of a combination connective tissue and fluid-filled environment known as the endoneurium, and then encased by a connective tissue perineurium, forming what's called the fascicle. In a polyfascicular nerve, multiple fascicles are then grouped together, invested and surrounded by an internal and external epineurium, respectively. At each one of these levels, one can find small blood vessels, lymphatic vessels, and nerves that supply, drain, and innervate the nerve tissue. They're often referred to as the vasa nervorum or the nervi nervorum. And in some nerves, you'll find surrounding the external epineurium a loose connective tissue sheath referred to as the mesoneurium. It's sometimes referred to as the paraneurium, which can be kind of confusing. So my preference is to use the term mesoneurium to avoid confusing paraneurium and perineurium. So this next slide shows a couple of different images that depict some of this anatomy. I really like these pictures in the upper left-hand corner, which shows a magnified gross dissection of a peripheral nerve, illustrates some of that internal fascicular anatomy, as well as some of the, if you look carefully here, the internal and external epineurium. And what it really does a nice job depicting is that loose connective tissue, kind of a mesoneurial nerve sheath. In the lower left-hand corner, you see an electron micrograph and a histological section depicting some of that intraneural fascicular anatomy. And on the right side, you see this cartoon, which illustrates some of that vasa nervorum and nervi nervorum. Jess did a really great job going over some of the pathophysiology of mechanical neuropathy, so I'm not going to get too much into this. I'll just call out a couple of important points that I wanted to highlight, is that with some of the adhesing effect, and I think Jay Ray mentioned this as well, the adhesing effect from the inflammatory response to the compressile insult, we do see this restriction of the normal gliding of the nerve relative to its surrounding environment. Often with the soft tissue fascial planes. But this also exists inside the nerve as well, is that especially in more chronic entrapment neuropathies, you get a lot of fibrin deposition and just outright fibrosis, which can not just restrict the gliding of the nerve in toto, but rather the smaller fascicles and other intraneural structures relative to each other, which is a hot topic of research as you look into this procedure. A full review of the biochemical pathophysiology of entrapment neuropathies is going to be way beyond the scope of today's talk, although my fellows can tell you that I love talking about that stuff. But I'll just kind of have a couple of call-outs just to mention here, is that when you have an entrapped nerve, often you'll get an increase of expression of various neurotransmitters, neurogenic inflammatory mediators, and actually some degenerative proteins and peptides as well. Another interesting finding. Some of the more common ones that are the common culprits we'll talk about is substance P, histamine, calcitonin gene-related peptide. In addition to the nerve expressing these peptides, you also see changes in the proteins and peptides and the channel proteins on the surface of the nerve cells themselves. These include various receptors and channel proteins, and probably the one that's received the most interest in recent years is the TRPV1 receptor, also referred to as the caspation receptor, and its important role in mediating neuropathic pain and symptoms. What's particularly interesting about the TRPV1 receptor is that it's a potential therapeutic target, as some in vitro studies have demonstrated that simple sugars such as mannitol and dextrose may actually block and modulate the activity of a dysfunctional TRPV1 receptor, which may have important implications when it comes to choosing your injectate for hydrodissection, which we'll talk a little bit more about later. So the rest of my talk can be summarized by this slide, and it's basically from a systematic review published in 2021 where the authors concluded that ultrasound-guided hydrodissection is a safe and effective treatment for peripheral nerve entrapment. But we'll dive a little bit more into this, and what are we actually talking about when we talk about hydrodissection? So let's talk a little bit about that term and that definition. The term hydrodissection itself is a relatively simple term, and it really just refers to the use of fluid in order to separate or pull apart tissue planes in order to expose different surfaces. It's not specific to a nerve. You can hydrodissect other structures. You can hydrodissect tendons. You can hydrodissect ligaments, other fascial planes. It's also not specific to the injectate, as any fluid medium can be used as your hydrodissecting solution. Another relevant procedural term that we'll talk about is adhesiolysis. And what that refers to is a breaking up or dissection or removal of adhesions. And recall that this is a big part of the pathophysiology of entrapment neuropathies. And then finally, the term neuroplasty is an interesting term. It's really an umbrella term which includes other procedural terminology such as neuroraphy, nerve release, neurolysis, nerve repair, etc. But as an umbrella term, neuroplasty reflects a change in the physical condition of a nerve or surrounding a nerve for the purposes of physically restoring the nerve from its pathologic state. And so if you look at all this, the term hydrodissection by itself is actually insufficient to describe what we're actually trying to do, which we'll talk about in a moment. But a more comprehensive and probably more accurate name for the procedure could be ultrasound-guided percutaneous hydrodissection adhesiolysis neuroplasty, which is a mouthful, right? So we're going to just stick with hydrodissection, but remember that we're not just putting fluid around the nerve, we're actually trying to change something in the nerve to have a therapeutic effect on some pathologic changes. So what are some of those goals as you're doing this procedure? So what we're going to be talking about is basically using ultrasound guidance to guide a needle alongside the nerve and injecting a fluid medium and taking advantage of the volume and pressure of that injectate to separate the nerve from its surrounding soft tissue tethers to accomplish two end goals. The first is to completely surround the nerve with anechoic fluid, and the second is actually to observe a physical change in the cross-sectional shape of that nerve. You see, most nerves that are unhydrodissected, and particularly in those that are entrapped, often have kind of a flattened or discoid appearance. As you can see, is demonstrated here in this example of a median nerve within the carpal tunnel of its kind of squashed or flattened discoid shape. But as you notice in the image on the right, as you're hydrodissecting that nerve, the nerve starts to assume more of a circular, round shape. And that physical change in the cross-sectional shape is one of the two end goals to a fully hydrodissected nerve. Right there. Okay. So how do we accomplish this? And there's a variety of different techniques, and there's two basic methods that we often teach as the first approach to hydrodissecting nerves. In the first method, what we're doing is we're trying to guide the needle to the nerve in a method where the long axis of the needle is perpendicular, or at least not parallel, with the long axis or course of the nerve. So they're kind of perpendicular to each other. You can accomplish this, for example, by imaging the nerve in short axis and using in-plane needle guidance to bring the needle towards the nerve. This is considered a safer, simpler, and technically more easier version of hydrodissection. It carries some other advantages as well. For example, you can hydrodissect multiple nerves in the same fascial plane with one skin entry point by using this method. However, it does have limitations. One of its bigger limitations is that you're limited in the length of the nerve segment that can be hydrodissected because of the angular length of the needle. And if you were to rely solely on method one, as described here, to hydrodissect a longer nerve, it's going to require multiple skin entry points in order to accomplish that. Here's an example of this. So this is a patient that I treated a few years ago. This is actually an image of the subpec minor brachial plexus. What we're seeing here is we're seeing a long axis image of the pectoralis minor right here. And I've got my power Doppler on, and I can see the power Doppler positivity of the axillary artery here. And if you look carefully, and this will be more obvious when the video starts, you'll see these fluffy kind of white structures that flank the artery, which represent the medial, lateral, and posterior chord of the brachial plexus. And we're imaging the brachial plexus here in their short axis image of that posterior chord. I'm going to bring my needle in plane so that the long axis of the needle is actually perpendicular to the course of the nerve, in keeping with method one. Now, a couple of technical points here is that it's really important to make sure you take the time to scan the environment around your nerve so you can take a good inventory of not just the anatomy of the nerve, but any surrounding other at-risk structures like the artery, and make good use of the Doppler in order to take a good inventory of that. So we'll let the video play here. I don't know why it's not it. There we go. Okay, cool. So again, I got that Doppler signal there. My needle's going to come from the left side of the screen, going in plane. I've got full-time visualization to my needle tip. Now, I chose to use a linear probe to show the anatomy, which does limit our ability to see the needle for steeper approaches, but you can see full-time imaging of that needle tip right there. I'm fully aware that there's going to be the axillary fascia that I'm going to have to pop through, so I'm expecting the needle to pop through the axillary fascia. So really strong knowledge of the local anatomy is important. And then as I pop through, I'm going to inject fluid to separate that posterior cord from the axillary artery. I'm also going to use my Doppler positivity to visually document that my injectate deposition is separate and external of the axillary artery for the utmost of safety. So you can see that there's all these different safety checks that you should build in when you do this procedure, especially when you're kind of flirting with not just nerves but arteries. So method two is a different method of accomplishing the same thing. In this method, what you're doing is you're guiding the needle in such a way where the long axis of the needle is parallel or collinear to the long axis and course of the nerve. You can accomplish this, for example, by imaging the nerve in short axis and using an out-of-plane needle guidance, walking down the needle towards the nerve. It's considered technically a more difficult difficult procedure, requiring a little bit more confidence and skill and experience to accomplish, but it does carry some advantages. And one of those is that it does allow you to reach anatomically tighter areas than, with more ease than method one. And also, if you choose a longer length needle, you can hydrodissect longer lengths of a nerve segment with fewer entry points into the skin. So here's an example. This is actually my very first perineural hydrodissection done about 13 years ago. This is a short, so this is making that as an excuse because this is a 2008 ultrasound machine. But you have a short axis image, a partial image of the Achilles tendon here, and just off laterally to that, we're going to see the sural nerve, and then I'm going to turn on Doppler, and you're going to see some small vessels to the right of that. Because I've done the Doppler image, I know I'm going to plan to bring my needle opposite of that just to maintain the utmost of safety. So. And this was a mimicker for Achilles tendinopathy, so just in keeping with Jess's theme there. So I turn on power Doppler, got to see the vessel there, and I'm going to basically bring my needle out of plane, and I'm going to bring it a little further away from the nerve on purpose. I'm going to inject some fluid in order to create some working space. And then within that anechoic working space, I'm going to then redirect the needle closer and closer to the nerve, injecting layer by layer, almost like different onion skins, peeling off layers and layers of soft tissues from around the nerve. And some of these layers actually represent fibrosis that have adhered to the nerve. And ultimately, I'm going to redirect, and as you can see my needle here, I'm going to try to end up with something like this, where the nerve is perfectly circular or pretty close to perfectly circular, and you have a nerve floating in a halo of anechoic fluid. Then I'm going to park the needle on top of the nerve, turn my ultrasound transducer 90 degrees, so I'm long axis to the nerve and in plane to my needle. I'm going to continue injecting to extend that ring of fluid into a cylinder or a column of fluid, and rinse and repeat until I feel like I've hydrodissected the entire length of pathology. So which nerves can we hydrodissect? Pretty much any nerve that you can see and reach, provided that you can have good command of the local anatomy and be able to image properly with Doppler imaging so you can take a good inventory of all the at-risk structures. Got to maintain that safety here. A couple of technical points I'll mention here. One thing I always advocate is to maintain continuous two-way verbal communication with your patients. I try not to do any nerve blocks before a procedure because I want the patient to be able to give me feedback as to how they're doing, how they're feeling, but more importantly, what they're feeling. You know, what symptoms are they feeling? Because I can correlate what they're reporting to me with what I'm seeing on the ultrasound image in order to really get an idea of what's actually happening at that needle tip. Because what I see on the image screen is still just a representation. What's really happening is underneath my ultrasound probe. So that's really important. It gives you good, useful information to maintain safety. The other point I'll mention is that hydrodissection is really a continuum. Smaller nerve entrapments will require smaller volumes, fewer skin entry points in order to accomplish your hydrodissection, while more severe, more significant, complicated cases are going to require more fluid, longer segments of nerves to be hydrodissected. And because you're dealing with higher volumes, the potential risks and the adverse effects or toxic effects of your injectate in your hydrodissection solution become an important consideration for safety. So it's important to keep that in mind if you choose to use local anesthetic, is that when you're doing high volumes, you got to keep in mind local anesthetic systemic toxicity. And what I learned a few years ago is that dosing by weight is a good starting place when it comes to trying to figure out what the max dose of lidocaine or anesthetic you want to use for your hydrodissection solution. But what's also important is that actually an individual's threshold for local anesthetic systemic toxicity actually is influenced by other factors other than just their weight. Their body composition becomes an important component when it comes to what degree of that nerve-blood barrier that you're dealing with. So these are important considerations, and this is probably the reason why I'm using more and more just 5% dextrose, because it's pretty safe. So what about the evidence for hydrodissection here? And if you look at the literature looking at ultrasound-guided perineural hydrodissection, the vast majority of studies are going to be surrounding carpal tunnel syndrome. So here's a study, randomized controlled study published in 2019, comparing ultrasound-guided hydrodissection with normal saline surrounding the median nerve versus a placebo or sham procedure where they injected that normal saline above the transverse carpal ligament. 34 patients, and what they assessed was symptom severity scores, function scores, electrodiagnostic parameters, and the change in the cross-sectional area of the nerve under ultrasound at 1, 2, 3, and 6 months. And what the authors concluded was that perineural hydrodissection around the median nerve outperformed their sham and placebo injection and supported the use of this procedure. This is a question I get frequently from fellows and other trainees. What about method 1 versus method 2? Is there any evidence to this? We've already talked about some of the logistical and practical limitations of the procedures, but here's a study, single-blinded randomized controlled trial published in 2021, comparing these two methods, looking at 44 patients and injecting with normal saline around the nerve, and they looked at symptom severity scores, electrodiagnostics, cross-sectional area under ultrasound at 2 weeks, and thereafter at 1, 3, and 6 months. What the authors concluded was that both groups improved compared to their baseline symptom scores. However, method 1 did eke out a little bit better than method 2 at 1 month, but after that, there was no statistical difference between the two methods. What about your injectate solution? And I've kind of danced around this topic for a little bit, and I alluded to that TRPV1 receptor and the 5% dextrose. Here's an interesting study published in 2018, double-blinded randomized controlled trial comparing 5% dextrose versus normal saline as your injectate solution for hydrodissection for carpal tunnel. And they looked at symptom severity scores, function scores, electrodiagnostics, ultrasound imaging of the nerve as well at 1, 3, and 6 months. And the authors concluded that that 5% dextrose outperformed normal saline. What about volume? And this is an interesting debate from all of us hydrodissectors. Here's a study published in 2020, double-blinded randomized controlled trial looking at perineural hydrodissection with 5% dextrose for carpal tunnel using 3 different volumes. And again, looking at symptom scores, function scores, electrodiagnostics, and the nerve cross-sectional area under ultrasound at 1, 3, and 6 months. What the authors concluded was that the larger volume group outperformed the other groups at 6 months in the symptoms and functional scores, but there was no difference in electrodiagnostics and cross-sectional area. A couple of limitations here. One is that the volumes used are kind of smaller than what many of us use in clinical practice. Perhaps if you use larger volumes, there might be a bigger difference. And then the other, of course, is that they only followed out to 6 months. What about outcomes after 6 months? And here's a study published in 2021. It's a retrospective review, but what they did was they did telephone interviews of 185 patients who had perineural hydrodissection of the median nerve with 5% dextrose for carpal tunnel syndrome. And they had a follow-up of at a minimum of 1 year. And they asked the patients if they had more or less than 50% symptom relief at that time point. And what they reported was that more than 88% of those interviewed reported more than 50% symptom relief that lasted out to past 1 year. They also noted that those who had a less effective response, a poor response, were more likely to have a more severe grade of carpal tunnel syndrome, not surprisingly. What about steroid? When I was in training, and I think it's still used pretty frequently, as corticosteroids are often used in perineural injections. And here's a study comparing 5% dextrose to corticosteroid under ultrasound guidance. A double-blinded RCT, 2018, of 54 patients. And again, looking at symptom severity scores, function scores, and cross-sectional area of the median nerve out to 6 months. And what the authors concluded was that in this study, that 5% dextrose outperformed the combination of triamcinolone and normal saline. PRP, we're all about orthobiologics. So here's a study, 2017, single-blinded randomized controlled trial comparing 5% dextrose versus PRP for perineural hydrodissection of the median nerve for carpal tunnel syndrome. Again, looking at symptom severity and function scores, cross-sectional area of the nerve, followed out to 6 months. And what they concluded was that both groups improved similarly when it comes to the symptomatic improvement, with a greater reduction in the cross-sectional area seen in the PRP group compared to 5% dextrose at 6 months. How about some other nerves? So, I see a lot of cubital tunnel in my practice. So this is a double-blinded RCT published in 2020 looking at perineural hydrodissection of the ulnar nerve about the elbow, comparing 5% dextrose versus normal saline/triamcinolone. They looked at symptom severity scores, electrodiagnostics, cross-sectional area, followed out to 6 months, and they found that there was both groups improved significantly, similarly, with a non-significant trend towards greater improvements with 5% dextrose. And the saphenous nerve, this is an interesting one. So in 2015, this is a retrospective review looking at 16 patients who had a total knee arthroplasty. So after their knee replacements, they had chronic medial knee pain. And what these 16 patients did is they underwent ultrasound-guided perineural hydrodissecting injection with a combination of local anesthetic and corticosteroid. And they reported that at 6 months, 75% of the patients improved at least 50%. And there's a whole bunch of other case reports and case studies, but in the interest of time, I'll just conclude by saying that entrapment neuropathies are important. And I do think they're underreported, but ultrasound-guided perineural hydrodissection neuroplasty is a useful tool in our toolbox, and very accessible if you can invest the time and training to learn this skill. But still, it is not really considered a beginner technique. It does require that investment of time and practice to get this done, to acquire those skills, to be able to do it safely and effectively. And we still have a lot to learn. To what degree is the therapeutic effect due to the mechanical adhesiolysing effect versus the pharmacologic effect of our injectate? We're not entirely sure. That still needs to be delineated, although it's probably a combination effect. Also, the ideal injectate has yet to be elucidated, but 5% dextrose seems to be a pretty good place to start. And then finally, I'll say that a lot of us hydrodissectors are looking into expanding hydrodissections, looking at limited intraneural hydrodissections, and that's something we need to be on the lookout for in the years to come as we get more advanced with this technique. And thank you very much.